All right, thank you, Dr. Pan, for doing that introduction. Thank you for everything that you've done and all the hosting that you've done to kind of lead to today, as well as to Dr. Cole as well. Yeah, I'm delighted to be here and thankful to be here virtually talking to you on two topics that are very much of interest to me, and hopefully for those of you both on the pain side, but more importantly for today on the anesthesiology side too, as we talk about how psychedelics and psychostimulants can interact with the perioperative time period. So as I get started here, a few shout outs, of course, to Dr. Pan, to Dr. Cole. Thank you for hosting. As I said, thank you for the invite to be out here doing this too. Some friends and colleagues and former UPMC alumni, Lily Paulsunas, her husband Patrick Paulsunas. Of course, I want to give a shout out to Stanford's amazing program director in pain medicine and current and outgoing president of the Association of Pain Program Directors, Meredith Barad. Tracy as well. Hi, Tracy, if you're joining too. And as well as a current fellow that was amazing as an anesthesia resident, Sherry Wang as well too. And of course, Michelle, thanks for everything that you did to facilitate this as well too. So with that, let me go ahead and get started here. I wanted to mention, for those of you who have a specific interest, or maybe this discussion piques your interest a bit, I've published a couple review articles with some friends and colleagues at Wake Forest on how to manage stimulants in the perioperative period and how to manage hallucinogen use in the perioperative period. And we're going to delve into it. And in fact, this is what the talk is going to be on. We're going to dive into these papers. And certainly I'd point you to both of those references if you're looking for more information on both of those topics. So let's start off with a little case discussion here. We're in 1959 now, and we're working in a lab in Detroit trying to develop a new anesthetic, okay? And this anesthetic that they're developing is causing an increase in the blood pressure, respiratory rate, and minute ventilation. And it is providing significant amnesia and analgesia, and it was developed by this company. And so they decided to test it a little bit more. They do a clinical trial, again, the end of the 50s here. Only 30 patients did well. It worked as an anesthetic really well for them. And as we all know in anesthesia, we haven't really found a great anesthetic if it's failed for 13 out of 64 patients. And in fact, 10 patients in this trial became agitated. They developed psychosis, and they were very difficult to manage. And what I haven't revealed is that the medicine that they had developed was phencyclidine, or PCP. This is what they were looking at. Not a great anesthetic if you're looking for something that allows someone to gently and gradually awake from a plane of anesthesia to come back to homeostasis. So the group continued to work on the compound PCP, and they ended up deciding to add a ketone group onto the amine, and suddenly it became this nice anesthetic, which we think of as ketamine. So the reason I put this slide in here is not because I'm going to focus on PCP or ketamine, although yes, I'm going to be talking about medicines within kind of the hallucinogenic realm, or medicines that are considered hallucinogens. It's to show you that what is maybe fringe in one era and seen as outlandish or crazy, if it's developed and if it's kind of tweaked and modified under a rigorous science, it can become standard of care in another era too. So yes, today I'm going to talk about a lot of different aspects of psychedelics and psychostimulants, and a lot of these compounds aren't necessarily ready for prime time. But just because they may be fringe today, it doesn't necessarily mean that they're going to be fringe tomorrow or 10 years from now too. So with that, let me continue discussing here. This talk really is almost two separate talks. Psychostimulants and psychedelics are unique topics with unique mechanisms of action, and there's different branches of each. And I'm going to try to organize it so I don't confuse the heck out of everyone too. Of course, there's stimulant prescription use, the stimulants that are used for ADHD or for focus or for things like that. And I'm going to talk about how to manage those in the perioperative period. What I really want to spend a lot of time is this middle arrow, the illicit or non-prescribed use of both stimulants and psychedelics. And I'm going to talk about, if you encounter one of these patients in the operating room, how you would manage them. Do you even know if you have a patient that is using these substances? Is it going to show up on a urine screen? How do you manage them? Is there withdrawal? And then on the right, I also want to talk about some research and novel therapeutic uses that I'm doing and others have done with the psychedelic class of medications as well too. So our objectives today, we are going to discuss the mechanisms of stimulants and their role in perioperative care. We're going to review the difference between a psychedelic and a hallucinogen, go over the mechanisms of psychedelics, and evaluate how stimulants and psychedelics can lead to perioperative issues, interactions, complications, and what you need to know about for your patients as well too. And kind of a general theme for this talk is, as I present these medications, I'm in no way endorsing them. A lot of these substances are not ready for prime time. They need further study. So I'm presenting, how you would manage a lot of these substances in the perioperative period. But more research is definitely needed for their use as far as clinical therapeutics, which we'll talk more about too. Okay, so let's talk about another company. Let's talk about another case, and some of you may have familiarity. I know there's a lot of experts within your department in this realm here too. Let's go back to 2024, early 2024, in the years preceding. Lykos Therapeutics was developing this novel or novel use or novel clinical use for MDMA for PTSD, right? And this was kind of the darling of the psychostimulant world, and one of the companies that had really broken barriers and tried to develop a new clinical therapeutic for PTSD when the psychiatry world really hasn't had many new options for this for years and years. There was a lot of promise behind this, and there still is a lot of promise behind this, I should say, for these clinical therapeutics. And they were approaching the FDA. And then last spring or late last spring, an advisory committee or an advisory panel voted that Lykos Therapeutics MDMA analog was not ready for prime time. And they kind of voted against or put the brakes a little bit on the development as far as FDA approval. And then fast forward to the fall of last year, the FDA themselves actually voted down, and they cited some issues with safety and how the trials were done, and if the patients actually knew if they had received MDMA or not. And basically, it put a big break on this field, this emerging field of psychostimulants as clinical therapeutics, not even for those molecules that were directly involved in this study, but other molecules. And so the group has basically reorganized and changed forms. And certainly the field is trying to reemerge from this hiccup last year. Now, interestingly enough, you can go to the NIH website and NIDA's website, and you can see that there is a specific interest at the federal level, especially with NIH, to research and develop new drugs, new medications that have potential therapeutic effect for specific certain situations like substance use disorders or depression or PTSD. And I'm going to talk about all this today, and we're going to kind of dive into it and talk about where we are in the research and where we have to go. So we should talk about why this issue is so important. Let's look at the Monitoring the Future report that came out of Michigan and some researchers. I have a picture of the 2024 report, but there's actually a newer 2025 report that just came out, which I'm going to summarize both. But I do want to keep in mind that substances, stimulants, and psychedelics, it's a very important issue because the prevalence is so great right now. For instance, midlife adults, 35 to 50, there's been a significant increase in cocaine and amphetamine use. That's the non-prescribed use of amphetamines. Now, there are some positive trends if you look at some of the data in young adults, but there are some areas of concern, the midlife adults for these stimulants too. Now, this is what I think is more concerning, and I do want to pause a second on this slide. I have in yellow the new 2025 data that came out too. Hallucinogen use prevalence continues to go through the roof, right? Look at this graph, which I've recreated from the report here too. And I don't even have the 2025 bullet point on that just came out. 9.7% of young adults, 18 to 30 young adults, report use of a hallucinogen, a non-prescribed hallucinogen, in the last 12 months. So the way I think of it is almost 1 in 10 patients that we take care of in this age group that come through the operating room may have used hallucinogens in the last year. and still rising in the midlife adult range too. And you can see there's like an inflection point right around the time of 2019 and 2020, where as other substances improve, and now we're finally making strides in some of the opioid deaths, and we are tending to find that the hallucinogens other than LSD continue to really dramatically rise. And so this issue is certainly important to any of those in the perioperative spaces. We take care of these patients. And I do want to stress that a lot of these patients may not even consider this something that's worth reporting to you in the pre-op bay before you take them back for their anesthetic. They just may not consider this a relevant aspect that needs to be kind of declared too. They may just kind of see it as something that's separate, and they don't realize that it may have significant and severe anesthetic implications too. Psychostimulants with abuse potential, the data keeps showing the number of deaths continue to rise. We start to talk about, the first and the second and the third wave of the opioid epidemic, and the fourth wave now with maybe the nitazines and all this. But others think this newer fourth wave is actually the polypharmacy in patients that have both opioids and psychostimulants as polysubstance abuse at the time of death as well too. So certainly there's a lot of concerns. That's why this is also relevant, because the prevalence of these substances continues to increase, and these discussions are under taught, and the psychostimulants and psychedelics classes of medicines are certainly underappreciated and under taught in general. So, wow, with that long-winded introduction, I am going to move in, and now we're going to break up this talk and focus specifically on psychostimulants, and I'm going to give you an example case, and then we're going to go through the perioperative management, and then we're going to switch gears, and then we're going to talk about psychedelics, and I'm going to define what they are, and then we're going to talk about perioperative management as well too, and then we'll reach some conclusions and save some time for questions as well too. Okay, so you're now the anesthesia team caring for a patient in the trauma bay after an MVA. It's a 42-year-old male. In the short couple of seconds, you learn about the patient before they arrive to the trauma bay. Really no medical history that you know about. Turns out they have a positive FAST screen, hypertensive and tachycardic, polytrauma, and now they're going to the OR for an XLAP and some orthopedic repairs as well too. And as soon as the patient's back in the OR, you actually kind of take a few deep breaths and start to look at the chart a little bit deeper. And you see written somewhere that stimulant use disorder is on the charts. Amphetamines. Does that change how you manage the patient? If the case was an elective case, would that change if you had brought them back to the OR? What if it's chronic use versus acute use? What about prescription stimulants? Do you stop prescription stimulants before patients go back to the OR? Let's talk about all of these right now too. So first, let's go into what we mean by psychostimulants. And the way I would group this today is I'd kind of subcategorize these into three groups. The first I want to talk about is amphetamines and the non-amphetamine derivatives like methylphenidate. And this includes methamphetamine. And these are predominantly dopaminergic side effects and clinical effects that you see. Yes, there's other neurotransmitters involved like norepinephrine, but these are substances that help and work largely in the prefrontal cortex and other parts of the brain like the locus coeruleus for the norepinephrine effects. But they really help with focus, especially if they're prescription stimulants. They can help reduce some of the noise that the brain may experience in the crosstalk. Some of that may be eliminated, but there's huge dopaminergic release at the level of the synapse, and even greater release with methamphetamine, which can cause such profound relief of dopamine into the synapse that you can have severe and profound effects, even to the point of oxidative stress that can actually lead to degradation of the neurons themselves. You also have the stimulant-based, the local anesthetic-based category of stimulants, which is cocaine. I'm actually not going to focus on cocaine as much today. I'll maybe mention it a few times, but I really don't want that to be the focus of today's talk. And then what I think is really the most interesting subcategory of the psychostimulants, the entactogen category. And for some of you, this may be a term that you haven't heard of, entactogen. You also hear it called the empathogens or empathy. And it's a super interesting class, MDMA being kind of the prototype molecule within this class, but I'll talk about a lot of others. And it's this hybrid molecule, MDMA, where you get serotonergic effects and dopaminergic effects, and they kind of balance each other out in a sense. So patients classically, and the reason that it has this name, empathogens or entactogens, is because patients develop this inward sense of trust or empathy when they're when they have these substances in their system. And in fact, in clinical trials and some studies have been done, that inward sense of trust really can be quite therapeutic in the sense of the cognitive-based therapy that may accompany it to help them with PTSD. But in this case, the serotonin release may be 8 or 9 times as high as the amount of dopamine release, and they kind of balances each other out, and you get the effects of both. The serotonin, specifically at the level of the CERT, packaging, it's basically reversed, so it throws more serotonin into the synapse and reverses that that transporter as well too. And so really it's a super interesting class of substances. This is just a cartoon that was from one of the review articles that we put out. And I'm not going to go through it, just to show some of the mechanisms of actions of stimulants. The one thing that I did want to mention is I wanted to point out number 6 right here. Presynaptic receptor activation can, as we all know, serve as a feedback loop to help decrease some further release. And that's going to come into play when we talk about some of the medications to help manage stimulant use as well too. And of course, over time, you can see a diminished effect, as we all know. As patients use stimulants, there may be a diminished effect at the level of the synapse as well too. So if someone's acutely intoxicated with psychostimulants, you're going to see these effects: hypovolemia, hyponatremia, others I have listed here, hyperthermia, rhabdomyolysis, potassium release, all things that are important that you may treat supportively. The one thing I want to pay special attention to is specifically the last one listed here with MDMA in the entactogen category, is the risk of serotonin syndrome. And that's one of the takeaways from today's talk, both on the psychostimulant side, but also on the psychedelic side, is when you're managing these patients, you have to pay specific and careful attention to the risk of serotonin syndrome. Let's look at a little bit more detail at the mechanisms of action of these substances. Just to make it not too overwhelming with this chart, I'm kind of showing different parts at a time here. So the first category, the amphetamines, amphetamine-like stimulants, predominantly dopaminergic, but they also can increase norepinephrine. If you're taking them as a prescribed substance, some very beneficial aspects like wakefulness, improved cognition, improved focus, increased energy. Methamphetamine, large releases of dopamine, predominantly dopamine, as I mentioned. There's the cocaine-based, the local anesthetic-based stimulants. And then there's the, excuse me, the entactogen category. You have MDMA, which is ecstasy, huge amounts of serotonin. You can see some of the desired effects or some of the effects that you get from this class. And then there's also some non-amphetamine synthetics like the COT derivatives or the cathinones, otherwise known as the bath salts, that in many cases, these substances aren't directly activating the serotonin receptors. They're working on the transporters like CERT to reverse its outflow and to release more serotonin into the synapse as well too. This slide here, I just want to show that there's a lot of variation in prescribed stimulants, and there's both non-amphetamine stimulants like methylphenidate or dimethylphenidate. There's racemic mixtures. There's ones that have like a smoother on and a smoother off. There's ones that have more central action as far as and more peripheral action. And in general, with these prescribed stimulants, the more central action, the better, because the peripheral action of these psychostimulants can lead to blood pressure changes and can actually create more issues in the perioperative period. And I'm going to talk about phentermine specifically as an example of one of the non-amphetamine stimulants that can create and sometimes quite a problem in the perioperative period too. So these are common issues to kind of summarize with stimulants: sympathomimetic reactions, tachycardia, hypertension, arrhythmias, all things that need to be aggressively managed if there's any suspicion. Again, you may not have a blood test or a urine test to show this in the heat of the moment for a trauma or an emergent case. General anesthesia may be beneficial to control some of the central stimulation with these patients and reduce their metabolic demands. although you can make an argument that regional anesthesia is nice to monitor their neurological status. So the beta blocker issue, right? This is the classic board question, and it's still kind of propagated in textbooks that are out there. It's one of those myths of anesthesia that kind of keep propagating through the class, not to use beta blockers due to the unopposed alpha adrenergic agonism if the patient is using a stimulant. And in fact, a lot of those studies really haven't panned out. Some of the initial studies that were done were actually done in an animal model or dogs, and they were small. And while it is true that you probably shouldn't use the general non-cardioselective beta blockers, if you're using a cardioselective beta blocker, you're probably going to be okay using it for this type of case. And I shouldn't say probably. There's multiple peer-reviewed publications that show that there's no difference in outcomes if you do use a cardioselective beta blocker. And if you use a mixed alpha and beta antagonist, that's still probably okay, although it may not be ideal, and there may be some better medications that I can think of. But the myth about contraindication of beta blockers is somewhat old as well too. Now, your best medications here are your benzodiazepines, your alpha-2 agonists, and again, that goes back to that diagram of the synapse that I showed you. The alpha-2 agonists can help serve as a feedback loop to help diminish some of the additional release into the synaptic cleft as well too. Propofol, remember your serotonin syndrome risks, especially with MDMA. Okay, it's hard not to mention serotonin syndrome without doing a review of the causative agents here too. This is where you get into trouble because so many of the causative agents are things that we use in the perioperative period, like methadone or methylene blue, or maybe the patient's also on an SSRI, fentanyl, lots of different medications. In addition now to the MDMA that can propagate and cause serotonin syndrome. This is very interesting too. MDMA is actually metabolized by 2D6, just like a lot of the opioids that we use are. And SSRIs inhibit 2D6. So it's kind of a double whammy, right? You may have SSRIs, like maybe the patient's on paroxetine or fluoxetine. Paroxetine is especially notorious for increasing the amount of serotonin. So that's increasing the serotonin because they're on an SSRI, and it's inhibiting 2D6 metabolism. So MDMA stays around longer, and that leads to more serotonin. And I wouldn't be doing my job on the pain side if I didn't mention SSRIs can also make your opioids not work if you're using an opioid that needs 2D6 metabolism to get to the active form, like oxycodone and oxymorphone. So 2D6 comes into play with MDMA for sure. This is just a summary. Again, I don't expect you all to remember all these or to necessarily see all these, but I really just wanted to point out that the benzodiazepine, these are going to be some of the main agents that you use to help manage some of the agitation, tachycardia, and hypertension. Your alpha-2 agonists, your direct-acting vasodilators if you need, the mixed alpha and beta antagonists. These are the substances that you want to keep in mind when you treat these if they're acutely intoxicated. This is for acute intoxication. Direct-acting vasopressors should be used. Avoid the indirect-acting vasopressors if possible. Chronic use of amphetamines does seem to have little effect on the MAC. There's pulmonary complications, of course, with these patients. Avoiding succinylcholine if possible as well too. So if you think someone's acutely intoxicated with a psychostimulant, first of all, you got to consider other diagnoses: neuroleptic malignant syndrome, thyroid storm, maybe even serotonin syndrome. If it's an acute intoxication, of course, if it's an emergency, you're going to take this patient back. It's an emergency, and you're going to take them to the OR. And you're going to cancel the case if it's elective and they're acutely intoxicated. And you're making all the modifications that we just talked about if it's an urgent or emergent case. Now, what's interesting is, what do you do about the patient if it's chronic psychostimulant use that is non-prescribed, right? If it's prescribed, you're going to have these patients continue their stimulants. What if it's non-prescribed? And let me go back here for a second. A lot of the data shows that it's actually safe to continue the case and not cancel the case if the patient admits to using a psychostimulant, a non-prescribed psychostimulant, if their vitals are stable. So if they have sympathomimetic signs like they're tachycardic, hypertensive, agitated, of course you're going to cancel it. But if they tell you they've used methamphetamine, 48 hours ago, their vitals are stable, the studies that have been done show that it is safe to proceed in those cases. Now, there are a few studies out there that actually say methamphetamine, because it is so deleterious and has so many effects, if they've used it within 24 hours, even if they are totally stable and their vitals are fine, you should still cancel it. But that was kind of a hedging their bets type of comment in a paper that's out there too. But in general, if patients are presenting electively, I'll just repeat this so it can sink in. If patients are presenting electively, their vitals are stable and they admit to recent stimulant non-prescribed use. If their vitals are stable, in many cases, it is safe to proceed to the OR and not cancel their case. Another review slide just to put in here. I mentioned neuroleptic malignant syndrome should be on the differential for anyone who presents. And it is sometimes difficult to separate from serotonin syndrome, especially in the heat of the moment, like a case. You can see the difference here. You get some hyperreflexia with serotonin syndrome. You also have, I didn't put it on here, you also have dilated pupils and GI changes with serotonin syndrome that you don't routinely see. So that's a good little barometer to keep in mind. Look for dilated pupils with serotonin syndrome. Neuroleptic malignant syndrome, the hyperthermia can be quite high too, higher than serotonin syndrome. This is just what I was monitoring. If it's an elective case, in many cases, if it's prescription use, you're going to continue. You're not going to have the patient stop it. You're going to continue the prescription in the perioperative period, the postoperative period. If they're acutely intoxicated with a stimulant, you're going to cancel it. But if they're not acutely intoxicated, you can proceed. Okay, that's a mouthful. I know these flowcharts are a lot to digest too. I often get questions on this, and I got questions on this recently too. At a different talk, what to do about phentermine. Now, phentermine is kind of a unique bird here as well, too. So as an appetite suppressant, it's often used and patients present with a prescription and being on this. It really works peripherally. And it's mostly working on norepinephrine release with minimal dopamine reuptake inhibition. And it can really deplete peripheral norepinephrine stores. So depending on what institution you are at, you'll see different policies of when phentermine could and probably should be stopped at various institutions because of this knowledge that's really depleting peripheral norepinephrine stores. Whereas a lot of the medications I just talked about, MDMA, prescription medications, they're more centrally acting. So you do get this steady state level of catecholamine, and they don't really become depleted. So you can manage these patients perioperatively. So it's interesting. It's actually one of the prescriptions that we have, phentermine, that may have more deleterious intraoperative effects than non-prescribed medications that were taken, a couple days before surgery as well too. Okay. All right. So let's switch gears to the second half of this talk. And it's at this point where I want to focus on this 43-year-old female. She has a lap appendectomy, and it's elective. She's on paroxetine, SSRI, stable dose for 5 years, and it's an uneventful anesthetic in case. In PACU, she has this set of vital signs: sweating, shivering, hyperreflexia, fentanyl given intraoperatively. So, of course, because we're doing this talk, she has serotonin syndrome. But why her, right? Everyone that goes through the OR on paroxetine given fentanyl doesn't develop serotonin syndrome, right? So what caused her specifically to develop this syndrome, and what exposed her to the risk of developing this that all the other patients that we take care of every day on paroxetine that get fentanyl didn't have? And that's where I'm trying to get at. A lot of these patients may not reveal. In this case, I set this case up to be someone who had recently used psilocybin. That was the kicker here. Fentanyl, psilocybin, and paroxetine led to serotonin syndrome. Okay, let's take a step back and let's define hallucinogens and psychedelics. Super interesting class of medications. Some general definitions, and there's even controversy over how to define hallucinogens. It's a broad category. Some define it as a category that alters thought, perception, or mood. It may or may not offer addiction. Some are without addiction, can induce memory changes. And in fact, hallucinogens could be a broad category, right? Ketamine, other NMDA antagonists, certainly at high enough doses, opioids can become somewhat hallucinogenic. You have psychedelics, cannabinoids, deliriants like scopolamine. But what I really want to focus today is not most of these substances. I want to focus on the serotonergic hallucinogens, the classic psychedelics. These are serotonin 2A mediated agonists, the classic psychedelics. This is where I feel like a lot of the education hasn't happened in yet, or we need to be re-educated on the role of these classic psychedelics, especially as maybe 1 in 10 young patients have used a psychedelic or hallucinogen in the past 12 months. Now, there's different ways to break down these categories. One way is to break them into 3 categories: the phenylethylamines, the tryptamines, and the ergolines, like LSD. Okay, we're talking about these because of the prevalence, as I mentioned. We're talking about those if you're on a pain service, because you may be managing these on the inpatient pain service, as patients may be having effects of these wear off. There's research going on, some really remarkable studies. If you look at some of the data published in New England Journal of Medicine and JAMA on single dose psilocybin for depression. Now psilocybin and psychedelics, they're not creating new neurons or doing something like that. They're basically altering the connections between neurons, and there's some element of neuroplasticity, specifically when you add in the cognitive-based therapy or the psychedelic-assisted therapy that often accompanies some of these studies that have been done too. Super interesting, though, when you think of a single dose making dramatic results for patients in the psychiatry world, and maybe someday in the pain or anesthesia world as well too. Okay, so let's talk about the phenethylamines. The molecule itself is similar to norepinephrine or dopamine. The peyote cactus is one of the natural plants that you can extract this from, the mescaline from. That is not the size to scale. That's what ChatGPT thinks how big that looks. It's much smaller, the peyote cactus. And then the NBOM category. The NBOM category, super interesting category of medications. It's definitely not ready, or may probably ever be ready for clinical use. It can induce violent behavior. It was actually developed, these NBOM molecules were actually developed for neuroimaging research, and they've kind of been funneled into substances of abuse or misuse as well too. We'll talk more about those in a second. Tryptamines. Okay, this is really psilocybin's class, or DMT. Psilocybin, otherwise known as magic mushrooms, is kind of a pro substance as well. It becomes dephosphorylated into the active compound psilocin. And then DMT, which is from ayahuasca and the Amazon basin as well too. Of course, LSD has been around for a long time, synthesized in the 30s, and I'm not gonna focus as much time on that, given there's more knowledge on that too. Specifically on the pain side, I did want to give a shout out to some of the clinicians that I've worked with, and others. This big list of authors that looked at psilocybin's use for neuropathic pain, and I will say, not that much evidence. The evidence is out there is low quality. But there may be some signal that psilocybin could be helpful for certain very specific conditions in certain patient populations, like cluster headaches or migraines or phantom limb pain. So you can't, the review of the systematic review that was done by this great group of authors, including Tim Furnish and Joel Castellanos at UCSD, really showed that the signal was weak, but maybe growing too, that there's some benefit. Psychedelics, kind of the unique thing about them that I didn't maybe give enough attention to on that introductory psychedelic slide, these are 5-HT2A mediated effects. So 5-HT2A receptors are found in the prefrontal cortex, the neocortex. They're also found in the visual cortex, a large population in the visual cortex, hence the hallucinogenic potential of these substances as well too. So whereas SSRIs kind of generally and universally increase the amount of serotonin that's available, the classic psychedelics are really specifically activating this 2A subreceptor, and that's generating very specific effects like visual changes or serotonergic mediated effects, which I'll talk more about too. Again, serotonin syndrome is on the list. Other adverse effects that you have to keep in mind if you're conducting a clinical trial using psychedelics or also taking care of a patient. As many of you know, there's a huge dose range of psychedelics that you hear about, from large quote unquote heroic doses to smaller micro dosing or microdoses that you may hear as well too. Many of these are 5-HT2A agonists, which I mentioned. But they're not only 5-HT2A agonists. They may work on some other receptors. I've just listed some of the different substances as well too. The tryptamines, the N-bombs, the phenylethylamines. There's other receptors involved. And like I mentioned before, significant and severe adverse effects for almost all the classes of these medications, these substances, I should say. Including, like, look at the N-bombs. I was talking about how they're not prime time material. Violent behavior, rhabdo, seizures, lots of severe effects that make these substances not great targets for clinical therapeutics, but also concerning if you're treating someone in the perioperative period. And LSD is a partial agonist at 2A as well. Severe side effects as well at specific doses. So supportive treatment is most common, and one of the big things about this class of these classical psychedelics is just acknowledging and recognizing the patient has used these. That way you can treat the risk and be prepared for the risk of serotonin syndrome. Benzodiazepines, supportive treatment with those, maybe the antipsychotics. Now, there's no specific antidote per se or reversal agent for psilocybin, although certainly cyproheptadine can be used for serotonin syndrome and blockage of the serotonin excess. So if someone's acutely intoxicated, you would cancel the surgery if it's elective. Detoxification would be best. And then employing all these measures for the urgent cases that you can't necessarily cancel. Again, the same list of serotonergic triggers you should avoid if you're suspecting a patient. So one of the things that I wanted to leave you all with too is there's an article in RAPM that was published a few years ago with Shalini Shah as co-author that was looking at the management of cannabis in the perioperative period. And one of the takeaways from that nicely done article was it really only takes 3 to 5 seconds to ask someone if they've recently used cannabis, because there's certain clinical manifestations that we need to know about if you're managing these patients. And I guess my thought is it only takes another 3 or 5 seconds to ask, have you recently used cannabis or any hallucinogens or psychedelics in the last several days? And those few additional words that you add into your pre-op assessment may find one of these 1 in 10 young patients or one of these patients out there that has recently used psychedelics or a hallucinogen, and maybe they're not trying to hide any of this information from you. They may just not feel like it's clinically relevant to tell you. You're going to see exaggerated responses to the sympathomimetic substances like ephedrine if someone is under the influence of a classic psychedelic. And you are going to see some ventilatory depressant effects of opioids that may be synergistic with opioids from the hallucinogen class as well too. So you could have a whole weekend conference or a lecture on some of the reactions to psychedelics and how patients experience psychedelics. And certainly some of you in the audience are experts on this as well too. And it's hard to just give one slide to what the patients experience. They may have the most common adverse reaction from the classic psychedelics, maybe hemodynamic changes, tachycardia, psychological stress. There doesn't seem to be a known physiologic dependence or withdrawal from this. And the state that the patients are in clinical trials and research is often referred to as a journey. And it's very much influenced by the clinical context and the setting that the patient is in. If this is within the context of a clinical trial, like what is the therapy that they're getting alongside their dose of psilocybin? Do they have a mask on or a mask off? Because that totally influences as well too. Prolonged psychosis is rare, but there is an ICD-10 diagnosis for prolonged psychosis as well. In general, the stimulants and the psychedelics may not be detectable through the point of care screens that we have in the emergency department or in the clinic environment that we have as well too. You may be able to detect LSD on some of the urine and blood tests that we do, or maybe even the dipsticks. But a lot of these newer classes are going to go undetectable. So it's very important that you discuss with the patients in the perioperative period if you do have somewhat of a concern for use of stimulants or psychedelics too. So there's significant safety concerns for both the stimulant and psychedelic class. As I mentioned at the very beginning, these classes aren't necessarily ready for prime time as far as clinical therapeutics. There may be some signals emerging in the data that they are going to get there at some point for very specific patient populations, for very specific diagnoses. And it's great to see there's industry leading the way to try to help bring new novel therapeutics as well too. So will you recognize the next patient that presents with intoxication of stimulants or psychedelics? And that's just my kind of call to action to think about including this in a 3 to 5 second blurb when you ask the patient if they've recently used cannabis. There's a lot of significant risks. There's a lot of there may be certain patient populations in the future that will find clinical benefits for it too. And 2 other slides to finish. I did want to mention this interesting case report. So take this with a grain of salt because it's a case report. This was a patient that had improvement in long COVID syndromes after the non-prescribed use of MDMA and psilocybin. So this was not in the context of a clinical study. It's a case report of a single patient or patients. And then this is a study that I'm doing at UPMC, or that we're getting ready to launch. We've been actually working on the approvals for the last 2 years. This is through a foundation at UPMC called the Beckwith Institute, who has funded this study, and we've also looked and applied for some NIH funding. At UPMC, we are going to take trauma patients who are in the trauma ICU who have a history of opioid use disorder. So these are very at-risk patients, right? They've involved with a trauma, so there's a risk of PTSD and depression. And these patients already have high opioid requirements. They have a history of OUD, and they have surgery, and then they're brought to the ICU, and we're going to administer a single dose of psilocybin to them in the ICU and administer psychedelic-assisted therapy with them and monitor them in the ICU for the next 12 hours after their dose with 2 guides or 2 chaperones. And then we're going to be tracking their acute pain scores and then tracking them after discharge for the next several months to look at some of their mood-related outcomes. And eventually this will lead to larger studies that we hope to see if single doses of psilocybin may lead to changes in both acute pain, but also chronic pain too. As psilocybin does have some potential to lead to neuroplasticity in the way that these apical and pyramidal neurons interact with different areas of the brain. There's some ability of these medications to change this default mode network that how the brain interacts with other parts of the brain. So again, not ready for prime time, but interesting to study within the setting of a clinical trial here at UPMC. So with that, I'm going to stop sharing my screen and turn it over to Dr. Pai Cole or Dr. Pan for anyone else that may have questions. I'm happy to answer any questions that come up too.
Thank you, Dr. Emerick. That was fascinating and definitely provided a lot of food for thought. There are a couple questions. The first one is in the Q&A. I'm sure you can see it as well, which is, what are your thoughts about the use of low-dose ketamine combined with remifentanil and propofol for TIVA? Is there a patient population where this combination may be problematic?
Let me take a peek. So that's without, I don't know why I don't see, the Q&A in the chat. Is that, okay, there it is. So this is, just to clarify, this is separate from psychostimulants or psychedelics. It's specifically ketamine, remifentanil, and propofol.
Yeah. Sorry, it's sort of a tangential question. If you have an opinion or data.
I don't have any data. I think it's a great question and something that I certainly know at UPMC that is commonly employed is a TIVA anesthetic as well too. Um, I I I would certainly um, think there are specific patient populations that ketamine may not be ideal for, but I don't necessarily think this would be different than any other ketamine contraindication that's out there. The classic types of patients that we avoid with ketamine, like history of schizophrenia, history of recent, neurotrauma or increased intracranial pressure, those types of things. But I don't necessarily. I think this is a common thing that we employ at our hospitals, um, and I wouldn't necessarily carve out patients that are specifically problematic for that group. But that is a little bit maybe away from the types of patients that I study here at UPMC with stimulants and psychedelics.
All right, so another question. This one is specific to stimulants and I guess microdosing. Um, any thoughts, and I'm reading the question. Any thoughts on microdosing and the risk of pulmonary hypertension or valvulopathy? Almost all of these drugs have action at 5-HT2B, which is why fenfluramine was withdrawn. This is from Dr. Heifetz, who's also interested in that space.
I Yeah, and I want to give a shout out to Dr. Heifetz as well too, who's world renowned in this area, and I am lucky to be able to have him on this talk too, given his expertise too. I think it's a super valid concern, even with microdosing. This risk is certainly out there. Um, I would love to hear your response on that too, but I think even with microdoses of some of these substances, it's a significant concern. I can't say I've seen any great data on it or what the cutoff in milligrams or doses should be too. It's a great question. It's a great question, Dr. Heifetz. If you have any thoughts on that too.
Boris, if you are in a space where you can unmute, I've allowed you to
Thanks,
speak.
Sheila, and
Yeah.
nice talk, Trent. I don't really have any thoughts because I agree there isn't any data, but it is something that people keep bringing up and looking at as people are taking concoctions of kind of unknown quantities and unknown contents of microdose psilocybin, and anyway, so that's
Yeah, no, thanks for the comment though. I think it's a fascinating topic and certainly something interesting.
cool. Thank you.
Moving on, does UPMC have any treatment options for patients specifically related to preparation for surgery? For instance, if you want to read it yourself, Trent, it's in
Yeah,
the
yeah.
chat. For instance, perioperative contingency management. If not, why are there future plans?
Yeah, I don't know if that's specific for stimulants or psychedelics. We do have a general algorithm that we follow of when our preoperative anesthesia clinics evaluate these patients and discuss with the surgeons of which medicines, prescribed medicines like phentermine, need to be stopped and how many days. As far as non-prescribed use, there really is no there. I think this is still an emerging area where we probably need better policies. I almost when I poll the anesthesiologists at our across our UPMC hospitals, every hospital seems to have their own culture and way to do this. Some don't have any problem taking a patient back to the OR if their vitals are stable and they've recently used a stimulant or a psychedelic. Others will cancel no matter what, and everything in between. So I think there needs to be, I think it's a great kind of call to action type of a question, if this is what you're referring to, that there needs to be better contingency plans and workflows kind of described for patients, not just at UPMC, but elsewhere on system-wide policies of what to do with patients that may not be acutely intoxicated, but may have recent use of psychedelics and psychostimulants.
This is a cousin to the previous question. It talks about, and this has to do with sort of patient adherence or patient, however you want to think about this. How long should surgeons wait after if the anesthesia team cancels a case on the day of surgery? And I'm assuming this is after patients have taken or screened positive for psychedelics or psychostimulants. And then is there a strategy? I mean, I struggle with this myself, so I'm going to ask it anyway. Is there a way for patients uh, on how you can ask them to stay clean, if you will? I'm reading this as is.
Yeah, yeah, yeah. I mean, first of all, I guess this is under the assumption that they had some vital sign aberrancy, or for some reason you decided to cancel it. Because especially for the psychostimulants, you probably should not cancel if their vitals are stable. I would say 3 to 5 days is usually the kind of the standard here. I know that's still a range too. I think 7 days is in many cases more than 5 half-lives enough for almost all these substances, and maybe a little bit aggressive. I know there are hospitals that say that you need to stop phentermine 7 days in advance. But in general, if the patient has vital sign changes and you do cancel a case, 3 to 5 days is what I would advise the surgeons to get them back on the schedule too. So in other words, yeah, telling these patients they have to avoid using these substances of abuse for 3 to 5 days.
Dr. Bleich, I'm probably butchering your name, Jeff. If you'd like a question, you're permitted to speak or not. Another question that's come up is there's a lot of PO ketamine sort of in ketamine clinics and other spaces, and people are, I think you can even order it online. At least in California, you can. And so, have you taken care of a patient that's been using ketamine powder or PO ketamine, I guess?
I I never have. Like in my chronic pain world, we certainly discuss it quite often with patients, that the troches of ketamine that get kind of compounded into these gummy substances. Um, Certainly, I think that the amount of data that shows that there's a clinical therapeutic use is low for daily ketamine of that type. If it's being misused or obtained through non-prescribed sources, I think I'd have significant concerns proceeding to the OR, given probably the large doses of ketamine and the resultant effects that you'd probably see, just due to depletion of the peripheral catecholamines as well too. So I don't I haven't seen that, and I haven't seen the powder form per se, or a patient present to the OR saying they've recently utilized a powder. But I'm guessing it's probably on a high, magnitude of milligrams that they're taking that would give me significant concern to proceed to the OR with it too.
And then while people are thinking of questions, something that came up in our ICU practice is, do you see a role for, I mean, we've thought about ketamine as an adjunct for pain, and therefore, reducing opioids in the ICU, but a lot of them have delirium associated with it. So are you aware of data that might help, you know, that one way or the other with ketamine in the ICU?
Yeah, I don't. Ketamine in the ICU isn't something I can't say I'm an expert in that data too. Um, I wouldn't be able to give a good answer for that too. I just haven't studied ketamine in the ICU. Um, I will say, like, we use ketamine commonly in the pain clinic. We have outpatient infusions, and it's hard to find good data there that it does improve outcomes. It doesn't reduce MMEs. It doesn't reduce pain scores. It does seem to reduce hospital healthcare utilization, like emergency room and urgent care visits. So I don't know if there are corollaries to the critical care data that show that, although it's something that seems nice to add and we feel like it's opioid sparing, I'm wondering if the data may not bear that out, that it does lead to earlier discharge or improved outcomes for critical care patients too. I think it's a great question. I just don't have that expertise.
Two more questions have popped up, and we have 4 minutes. So the first one, brittle psych patients needing long titrations of mood stabilizers. How do you counsel patients regarding risk of self-harm versus holding SSRIs, SNRIs, and atypical mood stabilizers?
Great question. Great question. So, yeah, these patients, obviously, we're not doing this in isolation, and it should be done in conjunction with their psychiatrist. And hopefully, the majority of these patients are maintaining and not stopping these vital medicines in the perioperative period. In most cases, if not all cases, they should be continuing their carefully titrated SSRIs, TCAs, because of the rapid destabilization that could be experienced in the perioperative period. So we may think we're doing them a favor by reducing, another serotonergic medication, but I can't say we have or I've seen a protocol that's advising to universally stop these types of medications for high-risk patients too.
Okay, so when thinking of sports and football players, how do you balance the immediate need for effective pain relief and the long-term health consequences and legal regulations of substances? This is in chat in case you're reading along. What innovations or strategies do you think will shape the future of pain management in professional football? What would you say to young players who are just starting?
Yeah, I think there's such a pressure. It's a great question and probably could be a lecture by itself too. There's just such a great pressure, and we live in this ultra competitive society, whether it's professional athletes or even high school or college athletes or medical school, the rates of stimulant and psychedelic use are through the roof. There's studies that have astronomical percents of prevalence of substance use, like benzodiazepines and hallucinogens for medical school students as well too. So it's really hard. I don't know if I have a single great answer other because it is hard to show, especially a young athlete, the long-term effects when they're trying to beat someone else out for a position and see this as maybe a way to get a competitive edge that can go undetected. So I think it's an important discussion to have with them and let them know that these are things that can quickly ruin their career if they are detected. And even though certain institutions or professional societies, sports societies may not have specific policies about it regarding hallucinogens or psychedelics, there's so many harmful things, and there probably isn't a whole lot of competitive advantage specifically for the psychedelics. I mean, you could make an argument that maybe for some of the amphetamine derivatives there are, but that should probably go within the context of a prescription as opposed to non-prescribed sources too.
Okay, with that, thank you again, Dr. Emerick. This has been a fascinating conversation. Have a great week, everybody, and we will see you next time.